this breakout room. I just wanted to give everyone the heads up so that we capture all this great information. I'll start off by introducing our two managers who will be with us here today. Heidi Tani, who will be representing the Med-Surg, and Todd Bartholet, who will be representing the ICU and PCU. So maybe we could start off, Heidi and Todd, could you tell us a little bit about life on your unit?
Todd, I'll go first. Hi, good morning, everybody. We're really excited that you're here. I know that Todd and I are both very excited about what we do and who we work with every single day. So like Nick said, I am the manager of our medical and surgical oncology patients, which is a floor of 36 beds. We take care of both medical and surgical oncology patients. So our name is very, very indicative of that patient population. So the types of patients that we have on the surgical side, they're those individuals coming out of surgery, whether they've had a tumor removed, maybe they've had to do some rerouting of organs around a tumor, kind of things like that. They end up coming to our floor after their surgery. So our main populations are gynecologic oncology, urology, colorectal, other complex GI things are the major ones. But we also dabble in a little bit of head and neck, thyroid, kind of anything under the oncology realm we would do. On the medical side of things, a lot of the oncology patients are treated outpatient anymore. So when they come into the hospital, they're usually sick with something. We're coming up on cold and flu season, which feels like we've been in cold and flu season for about 18 months now. But we're coming up on the real cold and flu season, so we'll see a lot of respiratory stuff. Those patients, maybe if they're not tolerating their treatments, kind of things like that, they'll end up on our floor. We do have a decent amount of palliative care end of life. Obviously, our goal would be to get somebody to survivorship, but that's not always possible. So if needed, we would do end of life hospice care at the hospital.
All right, I can talk about ICU and progressive care. Both units work well. The tower works really close together as a whole, but on 6th floor, it's split up between two units. It's a 24-bed progressive care unit and a 12-bed ICU, and we really work very close together on patient movement. As also, just the staff are they all know each other really well, and so they support each other when needs arise. The ICU is a 12-bed unit. We are, I would say, predominantly a surgical oncology. That's our biggest population. We do a little bit of bone marrow transplant patients most of the time, or almost all the time. The transplants are done on the specialty care unit above us. But if the patients decompensate and need an ICU level of care, they'll come to us. If they haven't had their transplant yet and it was planned, it usually gets paused during that time. We also see a lot of head and neck surgeries. We see a lot of thoracic oncology surgeries. We see what we call a HIPEC procedure that we do quite a bit on our unit as well. And that is indwelling chemotherapy. We don't give a lot of chemotherapy on our unit. The HIPEC procedure, the chemotherapy is done in the OR. And those cases are usually quite long. So our surgeries come up most often at night and not during the day. But we also take overflow as well. So we're a busy unit. We're actually busier during the winter months, acuity-wise, than the summer months due to the cold and flu season and the oncology population. Progressive care sees a lot of those thoracic cases as well. They also see a lot of DKA patients, and then they see medical patients as well. And it's a 24-bed unit. We've had several nurses that have gone to either the Med-Surg, Heidi's unit, and progressive care, either or, before they come to the ICU. They get a lot of great experience when they do that. I've seen most new grads that have done that route actually transition to the ICU much more confident and much stronger, and it's not as a emotional challenge to them when they do that, and they perform really well when they go through that route.
Great. Thank you both for your opening answers. And for anyone who joined after my initial statement, I just wanted to let everyone know that this breakout room is being recorded. And if you have any questions, feel free to speak up or you can put them in the chat. Thank you for that opening remarks. Maybe you could talk a little bit more about your patient population, patient-nurse ratio, or RN-PCT ratio.
I'll go first, Todd. Ladies first, right? So on the med-surg unit, and I can also talk a little bit about the special care unit too. On our med-surg unit, it's pretty standard across the organization, which it is for all levels of care. For our nurse to patient ratio, we typically have during the day 4 patients to 1 nurse. At night, it's 4 to 5. On the specialty care unit, which Todd alluded to, is the bone marrow transplant unit. They also do some complex treatments such as like CAR T cells. They also take care of pediatric patients that need bone marrow transplants. They are a mixed acuity unit. So if they have a progressive patient where they could do pressors, a little bit more higher acuity, their ratios are, I believe, 3 to 1, sometimes 2 to 1. And then if they're in acute care, they'd be 4 to 1 as well. And then at night, about the same. So across the board in Nebraska Medicine, our care techs typically have anywhere from 7 to 9 patients, depending on the unit and kind of the size of the unit and how it breaks down. But that's pretty standard across the organization. We're very fortunate at Nebraska Medicine to have those smaller nursing ratios. Even during our most stressed time this past year, we were able to pretty much keep the same nursing ratios. We typically would pull our leads into staffing before we would try to increase those ratios across the board, or have people pick up extra shifts if they would like to kind of come in and help, even if it's just for a few hours. So we're very fortunate at Nebraska Medicine that those remain stable. I know other organizations, and probably some maybe that you've done clinicals in, that might not always be the case, but at Nebraska Medicine, we really try to keep those ratios at that point so that you can feel like you're providing quality care to your patients and really being able to focus on what's going on.
So for the ICU, typically our ratios are 1 to 2 ratio, sometimes 1 to 1. We would go in non-COVID times. You may get a third patient if you have a progressive care patients waiting or med-surg patients waiting for a room. And progressive care is 3 to 4 ratio during the day, and then 4 to 5 at night. However, during COVID, it presented a lot of challenges for us. Heidi can probably speak to this as well, but we had to open up a COVID unit that was both med-surg and ICU levels, and Heidi ended up opening up a ICU level COVID unit. With that, we did not have staff for that new unit, so all the ICUs had to help give staff to Heidi to manage those patients. And so during this early COVID times, we had to work on what we called team-based nursing. And we started bringing in nurses from non-ICU level care to be extenders, and they could do certain tasks that would be to the care of the patient, and the ICU nurses would focus on the ICU things. And in those times when it was we were really busy with COVID, we did have nurses taking 3 to 4 patients in the ICU, but they would have an extender with them. Typically, the extender there would be 2 ICU RNs and 1 extender assigned with them. And that was what we would do in that time. Other than that, the ratios typically are 1 to 2 ratio for the ICU, 3 to 4 for progressive care.
Thank you both for your answers. Any questions so far? All right, well, maybe next you could tell us each about something that would make your unit ideal for a new grad.
I can go first. We have hired new grads in our unit. The great thing is on our unit and on the tower as a whole we're very supportive of each other, and so we've been successful and making new grads successful. It is, I always am skeptical to hire new grads because the ICU is a much more stressful place, just because the demands, the families, the patients, the doctors, and your peers all expect you to have this ICU level. And so I myself started out as a med-surg nurse and felt that that was a good way for me to go. It helped me build a core base of my nursing knowledge. So when I came in, I could focus on getting over that task-based nursing philosophy and moving to thinking through the whole story of a patient care. And once I was able to do that, then the transition to the ICU was a lot easier. When you come to the ICU and you're focused on tasks, you're not paying attention to that whole story all the time. That can be kind of challenging, and it can be stressful. And healthcare it can be very stressful too. And so that's a challenge with ICUs with new grads. We try to balance it so we only have maybe 1 or 2 new grads coming off orientation each season. But that's kind of how we've done new grads. I'll let Heidi go now.
We on med-surg oncology are really used to having new grads. Kind of like Todd said, I think one of the great things about our unit is that you see a wide variety of patients. I know that there's sometimes, everybody's like, I want a higher level of care. I feel like on our unit, we do still get to do a lot of really interesting things. We're involved in research. We have cardiac drips. We have heparin drips. You still get insulin drips. Like, you still get a lot of those complex patients. And you do have to know a lot of things. Like, you have to be well versed on a wide variety of things. And our unit teaches you how to care for a medical patient, how to care for a surgical patient. You understand that why, and that why that leads up to them maybe even needing to go to the ICU, or after they're coming out, like how they can get back to their baseline so that they can go home safely with their family and continue on with whatever treatment that they're on. I think one of the things that we do really well throughout the tower, like Todd said, is we have really great teamwork. So even when we have those complex patients, my unit is pretty known throughout the hospital for calling the most rapid responses, which means that it's a patient that's deteriorating that you want to get off the unit, or you need extra set of hands to kind of take care of them, potentially to get them to a higher level of care before they would code. We call a lot of those on our unit. They end up a lot of times they end up on Todd's unit. And because of that, like, our teams work really, really well together, even just throughout the tower, being able to get patients different places that they need. But you really understand that why of what's getting them to that point, so that you can call an RRT before you have to code a patient. We have a really supportive nursing environment on med-surg oncology. My nurses work together really well. They love to learn. They love to ask questions. It doesn't matter how much experience you have. The ability to ask questions and not feel afraid to ask questions is really, I think, something that sets you up for success, no matter how much experience you have, but especially when you're a new grad. No question is off the table. And I think our units, and I know Todd's unit does this as well. It's really supportive of that learning environment. We're an academic hospital. There's learning that goes on all the time, and being able to recognize, that you have a team with you to take care of a patient helps with that. And so being able to have that teamwork, that friendly environment, that environment that allows you to ask questions, really just allows all 4 of our units in the cancer center to really excel. We have a really great team in the cancer center as a whole. And I think each individual unit has their own expertise, and we really rely on the other units too to kind of help support that.
I would add to it, Heidi, the teamwork is not only just with the nurses and the techs, it's also with the providers. In our tower, our nurses build great relationships with the doctors, and teamwork really is so evident when you're there, that it also, they just help out a lot. And And when nurses are able to ask questions, the doctors do a really good job of explaining it. And that's probably what sets really Nebraska medicine apart from a lot of other places, is that relationship with the physicians and other ancillary services that I just, having worked at other places, you just don't see.
And similar to my last question, what would make each of your units ideal for experienced grads? Experienced nurses, I mean.
So, I would probably say the culture of our tower as a whole is pretty phenomenal. There's a lot of support from staff in general. It's great to see, like, even when we have our ancillary services, so our EVS people, when it's their birthdays, our nurses do stuff for them. And the same thing with our X-ray techs and our respiratory therapists. They're included in the tower as a group, and it's really cool to see. The experiences that you get at Nebraska Medicine with all the options and what we do at this hospital is pretty wide ranged. And so experienced nurses really can flourish, and they can find a place for them that's really going to suit them well, just because there's so many opportunities.
Todd's still part of my answer, but I think like the other thing that I would say is that our cancer program at Nebraska Medicine is a world-renowned cancer program. So despite whatever type of experience you have coming in, you're coming into a program that's very highly respected in the city, in the region, in the country. We do things that other people don't do. So no matter what type of experience you have coming in, there's always something new that we're going to be doing, whether it's research, whether it's a new treatment. We, like Todd said, we work really closely with our academic teams, like that multidisciplinary team, to take care of our patients. And I think that's not something that you see. Granted, I might be biased because I've been here my entire career, but that's not something that you see traditionally in other hospitals. We do a really great job with that. And you also get to do a lot of different things. I mean, we do research on the floor all the time, whether it's nursing research or oncology research. I know the ICU participates in a lot of that stuff. So at whatever stage of your career you're at, those things are exciting, and they continue to push you to be that best nurse that you can be, for you to use all those skills that you learned in nursing school or learned at another position, to apply them to really see positive outcomes for your patients. And I think that that's one of the cool things too, no matter what age you're at, about Nebraska Medicine. They really do push you to be the best nurse that you can be and to work at the top of your license. And they expect, like Todd said, they expect that you know what you're doing, that you're a high quality nurse. And Todd and I, and our other managers in the cancer center, we really are invested in our staff, and we really want to see them succeed. And so we have set up, systems in things to help promote that support for our nurses and our care techs too. But most of the people here are nurses, or all the people here are nurses. So.
Any questions so far? All right, maybe next, if you could each speak to the individual units, the med-surg, ICU, and PCU, and talk a little bit about what makes each unit unique or different.
For ICU, it's really the level of care is what makes it different. We have patients that can be very, very sick. But progressive care, they have very, very sick patients, and likewise, so does Heidi's unit. But I think what makes our unit different, we're so blended as a tower, it's hard to say that one unit is a lot different than the other. Staff know each other from floor to floor, and I don't know how to answer that question. Heidi may have a better answer for that.
Todd, I think I would agree with you. But I also think like one of the great things is that we all kind of have, like, while we all share patients throughout the tower. We all have a little bit of a niche, and I know that like if we had a question, we were giving chemo on my unit, I know that I could call the special care unit to help with that if it wasn't something that are a type of chemo that we traditionally see. We know like our staff, like Todd said, works really well together. We share a lot of the same patients, which is nice. When we were opening the cancer center, we've been open for just a little over 3 years. That was one of our goals, that our patients wouldn't know a difference in the quality of care. They would just notice a difference in the color of their walls. Our rooms are all set up pretty much the same. The ICU is a little bit different because they have different needs. And so being able to not just have different colors of the room is really nice. So to answer the question in the chat, which is a great question, all of our tower is oncology. So Todd and I both work out of the Werner Cancer Hospital. I'm sure that you guys have seen it. It's, that very large addition off the main hospital. It usually is lit up at night with different colors. Right now it's pink for breast cancer awareness. There's three floors of inpatient nursing, 108 beds total with those 4 units. So the med-surg unit, the specialty care unit, or special care unit, the ICU, and then the progressive care. We are on 6, 7, and 8. So also in our tower, we have an infusion center, our oncology clinics, radiation oncology. All of our cancer care is done for the most part within that tower. So we're very fortunate. Our patients are very fortunate to have a place where they can go, where instead of having to go all over the hospital to get all their stuff, they really can just move up and down the elevator to their various places, which if you're not feeling well is really, really a great thing. Plus it allows, like Todd and I have talked about, just that teamwork throughout everything. In addition to the hospital, there's the research side of things. So it's a big L-shaped building. If you've never kind of seen it from all angles, there's 98 research labs. So we are basically across the hall from a whole research tower, which allows us to really interact with not only like our physicians, but also the scientists behind some of those new and novel treatments or diagnostic tools, kind of things like that. We're very close to them. I think that other thing too, about just if we're talking about the tower, we have a sanctuary and we have a healing garden, which our patients go to all the time if they're able to. And we're able to kind of get outside in a controlled environment or go to a very peaceful place. So not only do we provide like really great medical care, we try to bring in that holistic care to the patient. Todd's patients don't necessarily get to go down to the garden or the sanctuary, but my patients do.
Sometimes they do. We've been able to take patients who are on long-term events that maybe in the ICU they're a little more stable, but we're trying to find placement. We'll take them down to the sanctuary. We've taken them outside before as well. It's tricky, but you can manage it.
Go ahead,
Can I
Heidi.
ask a question? How many of you know somebody with cancer? Probably almost everybody, right? What's your interest in oncology?
I can go. I have had, my family has been largely impacted by cancer. So on both sides of my family. So, and many of them have came to Nebraska Medicine. So just their experiences have all been amazing. They talk very, very highly of their experiences. So that was my main reason for selecting the breakout room.
Thanks for your answer, Carly. Would anyone else like to answer?
Just from like a personal perspective too, that's why I got into oncology care. And I've been in oncology for 14 years, and it really was just, having that impact from personal experiences with my dad and with my grandfather, and just like seeing the way in oncology that providers or healthcare workers interact with patients. I might be biased because I've done it my entire career, but you'll never meet a better patient population. No matter where they're at, they really have a desire to get better. They have a unique perspective on life. They make you really appreciate just like the little things, like your morning cup of coffee, or the fact that you can go and hang out in a socially distanced and appropriate way with friends, and just being able to do stuff like that, or celebrating just like little things, they really give you that perspective. And as a nurse, they really a lot of times live vicariously through you and some of the experiences that you're having, especially when they're in the hospital. We get to see our patients multiple times. They come in and out, and you really get to form that bond. I think it's a lot. Nobody wants to be in the hospital, but if you know who you're going to see in the hospital, and excuse me, that support system that's there with your nursing staff and your care tech staff, that really can be a lot more comforting when you're walking in and you're like, oh, hey, Joe, welcome back. Sorry to see you now, but we're here to support you. You get to build those relationships with your patients, which on some other disciplines, you don't always get to do that. And I think our patients in turn are very grateful for the care that you provide them. They know that you're there at 3 a.m. to talk to them when they're trying to make a decision about what they do. And I think that's one of the things that's really special about oncology. It's one of the things that I love about it. It's one of the things that really can fill your cup. It's hard. It can be difficult at times, but I think the joys that you get from caring for those patients and celebrating with those patients outweighs some of those tough moments. And when you do have those tough moments, you have a really great team behind you to support you through that. I know Todd and I both have talked about just like that support system that we try to have there for our staff, because it does get tough. I mean, healthcare is a tough profession at times, and you deal with a lot of really, really sometimes morally, ethically challenging situations. And being able to have that support system, which I feel like Nebraska Medicine does a really good job of providing that support system, having that support system around you can help you get through some of those tough times. And it makes it even better when you get to celebrate really great things. Seeing somebody go home, being there when somebody tells them that their cancer is gone, those are really, really wonderful things to be a part of. And they make some of those tougher moments a little bit more bearable and unbearable. I don't know. Sorry, I just hijacked the mic for just a little bit, guys.
Well, I know we got 1 minute left, so I would just second to Heidi. It's the population that we care for. Our staff love it. It's highs, it's lows. It's what sets the tower apart from the other towers. I didn't come from oncology before I took this job, but yeah, it's been great, and the staff love it.
Well, thank you, Todd and Heidi, for all the great information you've provided. I think we're about to return, so thank you everyone for joining as well. And if you, in 10 seconds, it'll be automatically sent back to the main room. And also if you hit the leave breakout room button, it'll send you there right now.
Welcome back. Hope you guys enjoyed your little breakout rooms. I'm going to go ahead and share my screen again. While I'm sharing my screen, if you guys want to type in the chat function what your favorite thing was about your breakout room, or maybe what you learned that you weren't expecting to learn, we would love to read those comments. Okay, so Sue, if you're ready to go, we can definitely get started with you, and then you can announce your winner and all that.
I'm going to announce my winner at the end of my session, if that's okay.
Perfect.
Okay, so good morning, everyone. Welcome to Nebraska Medicine's first virtual open house. Thank you for joining us on this little dreary Saturday morning, but thank you for being innovative with us. It's kind of fun to do. I love to see the breakouts when everybody comes back. It's really kind of cool. So I'm just going to take a few minutes to talk a little bit about Nebraska medicine, about Nebraska medicine nursing, and a little bit about my story. Next slide, please, Erin. So not sure if you're aware, but 2020 was named the year of the nurse and the midwife. And we celebrated this in nursing forums in January at Nebraska Medicine, just as COVID was starting. And who would have thought, any of us, who would have thought that the year of 2020 would have so much for nursing? It's been a very unique year. It's been an unprecedented year, but how wonderful the opportunities that all of us as nurses have had during this year. Next slide, Erin, please. Here are some of our COVID unit staff members. Just wanted to share some pictures so you can see some of our colleagues. And so let me tell you a little bit about Nebraska Medicine. So in the Metro Omaha area, we have 3 main campuses. We have the main campus that most people will think about at 42nd Street between, well, now it's between Dodge and Leavenworth, really. It's on the same campus as UNMC. But we also have Village Point out at about 168th to 180th and just by Village Point Shopping Center. And then we also have our Bellevue campus. We have 2 hospitals. One is called Nebraska Medical Center, which is the main campus one at 42nd Street. But then we also have a hospital inpatient tower at Bellevue Medical Center, which is on 370, just off of Highway 75. We have more than 800 licensed beds across the 2 inpatient hospitals. But we have care that extends across the region. We actually have about 40 specialty and primary care health centers. And we actually have clinics in Lincoln at the health center on UNL's campus and also out in Grand Island. So you can see that our footprint is starting to spread across the state and not just in Omaha proper. We have more than 1,000 physicians.
Hello, everyone. My name's Nick Wasley. I work in talent acquisition at Nebraska Medicine, and I'll just give it a couple of minutes to see if anyone else joins the breakout room.
Is there any way that they could transfer me to a different one? I was in this one the first time.
Sure.
All right, sorry.
I asked for help from Tara Nicole, so hopefully she'll pop in, and then once you see, there she is.
Hi.
Hey, Tara. Nicole was actually in this breakout room last time. Is it possible to bring her back to the main area?
I sure can.
Thank you.
Yeah, no problem. Sorry, I'm just scrolling down to find you.
Thank you.
Nicole, what room did you select as your second choice?
It was the ED and PES.
Trauma. Perfect. I'll send you straight there. Thanks.
Great, thank you. And then I'll go ahead and get started. And this is the breakout room for oncology. And I'd like to remind everyone that I am recording the breakout room to capture all this great information. And I'll start off by introducing our 2 managers. We have Heidi Tani, who will be talking about the med surge, and Todd Bartholet, who'll be talking about the ICU and PCU. So maybe we can, oh, and I'd also like to mention that if you have any questions, feel free to interject and speak up at any time. And also there's a chat function and you can type any questions you might have in there. And I'd like to start off by asking Heidi and Todd, just tell us a little bit about life on your unit.
I can go first. Heidi, well, our unit is a 12-bed ICU. We share the same floor with a progressive care unit that is 24 beds. Both units work really closely, well together. The ICU, both ICU and progressive care see the predominantly more of surgical oncology. We do some medical oncology, and then we do a percentage of BMT population, which is the bone marrow transplant population. The bone marrow transplants are typically done up on the specialty care unit. They come to the ICU if they have a need for a higher level of care. Culture-wise, the tower works really well together, and so that's what kind of makes our unit stand out. But that's pretty much it our surgical oncology, we do a lot of head and neck. We do a lot of thoracic, and then we do some what we call like a HIPEC procedure. So we do some of that type of stuff. The HIPEC is indwelling chemotherapy they do during the OR, and those patients are pretty sick when they come up, but they do really well.
Perfect. Good morning, everybody. I'm glad that you're here to join us today. I know Todd and I both feel very passionate about what we do, so it's fun to see other people that are interested in oncology. So my unit, the Medical and Surgical Oncology Unit, is really a unit that cares for a wide variety of cancer patients. We have a lot of patients in our surgical population and a lot of patients in our medical population. There are a wide variety. We don't see just one type of cancer or care for one type of cancer. We pretty much see almost all of them with the exception of the blood cancers, the leukemia and lymphomas. So from a surgical standpoint, a lot of times we're getting our patients out of the ICU, or not out of the ICU, sorry, out of the PACU, out of the OR. Occasionally they come from Todd's unit from the ICU, but truly when they come up there, you know, they come up with lots of drains and tubes. We really care for, you really become an expert on that post surgical patient in the care for them and the management of them. Our main populations for those are, we are the exclusive place for our urology patients, gynecologic oncology, colorectal. We do some complex GI are our main populations. We also dabble in a little bit of thyroid, head and neck, plastics, kind of things like that. So like I said, really a wide variety of patients. On the medical side of things, our oncology patients typically are receiving their treatment outpatient. So whether that's chemotherapy, radiation, immunotherapies, whatever that might be, a lot of times they're doing that outpatient. So when they're admitted, they're sick with something. So we're coming up on cold and flu season. Feels like we've been in cold and flu season for a very long time, but we're coming up on it again. And so, you know, we might see our patients with that. They might come in if they're not tolerating their treatment. Maybe their kidneys or their heart or, you know, their liver are having issues. They come in and we try to figure out what's going on with the medical team and help fix whatever's with that. We do have a decent amount of palliative care, end of life care that we do on our unit. Obviously our goal would be to get all of our patients to survivorship, but that's not always going to be the reality. So being able to provide care at the end of somebody's life, if you can't get them home with hospice or home to or out with like a hospice house, we would be able to take care of patients on our unit like that. And just as kind of like if you've never been to Nebraska Medicine, Todd and I work in the Werner Cancer Hospital. It has 4 inpatient units, and we have our ICU, a progressive care. We have a special care unit which does bone marrow transplant for both adults and pediatrics. They also do some complex therapies such as like CAR T cells and some high doses of chemotherapy. And then we have the med surg unit. So 108 beds. We provide a lot of oncology care. And like Todd said, our staff, no matter which unit you're in, you typically know the staff on the other units. We work really well together. Our leadership teams all know each other. They call each other for questions. Everybody kind of has a little bit of an expertise in something. And when we are unsure, we have friends that we can phone a friend and reach out and work really well together.
Great. Thank you both for your opening remarks. Maybe next you could talk a little bit about your patient population, patient nurse ratio, and RN to patient care tech ratio.
So I spoke a little bit about what our patient population is, and we do cancer care it's very our staff really we do take some overflow, but our staff really love it when we have the oncology population, which predominantly we do, but we do have beds that we do overflow with the rest of the hospital. But our ratios are typically a 1 nurse to 2 patient ratio. Progressive care, I'll speak to that. It's a 3 to 4 patients per nurse on the day and 4 to 5 at night. with COVID though, it really presented a lot for ICU. So we had to do something called team-based nursing. Heidi got to open up the COVID ICU when it hit, and they didn't have staff, so they were taking people from the other ICUs, which caused us to need to rethink of how we were going to provide care. And in that situation, we did have what we call team-based nursing, and we would have extenders they were nurses from other units that were non-ICU. They would team up with the nurses so that those ICU nurses could actually have more patients, with that extender nurse being able to give medications, do basic assessments, and kind of help out with like cares. And then the ICU nurses could focus on the critical part of the patient.
I think one of the things that is really great about Nebraska Medicine is just our patient ratios for both our care techs and for our nurses. For care techs, just at baseline, it's standard across the hospital. They take 7 to 9 patients, and they work really closely with the nurses on the cares for those patients. For the nurses, we also have it standardized throughout the hospital. So everybody that's in an ICU or progressive care or an acute care unit pretty much has the same types of ratios. So for acute care, which would be all your med-surg units, the ratio on day shift is they take four patients for every nurse. On night shift, it's 4 to 5. It kind of just depending on how many patients you have, how many nurses that you have that evening. And then as you go up in acuity, then your ratios get a little bit lower. On progressive care, it's 3 to 4. On ICU, it's 1 to 2. So yeah. I know that that's one of the things that Nebraska Medicine feels very strongly about, is keeping those ratios at a manageable level. I know that there are other organizations that I have colleagues at that they don't have consistent ratios like that, where they might say that they have 3 or 4 patients, but in reality they're caring for a lot more, which can pose some challenges for that. But Nebraska Medicine we are very fortunate that when we say that we have 4 patients or 5 patients, we stick to those ratios. And it's very important that for us to ensure that we're still providing quality care to our patients, that we stick to those ratios.
Great, thank you. Any questions so far from anyone? All right, maybe next, if you could each talk about what makes your unit ideal for new grads.
For the ICU, we try to balance new grads when we do take new grads. So we don't have too many new grads coming on at one time. But we've done it. Our educator works really well at making new grads very successful. We try to encourage new grads to try to go to like Heidi's unit first or progressive care, just because the new grads that have done that, when they do come to the ICU, they adapt really quick to the ICU. There's a lot of nursing that they learn on those units before they come to the ICU and really focus on the ICU part. That really helps out. And I think those nurses typically over time fare better. But new grads have come to our unit and have been very successful. We've had all our staff that have come to our unit has been successful in transitioning to the ICU level. It's just more challenging for them as a new grad. And sometimes I would like to tell people that you're already under a lot of stress when you start as a nurse. And if you're going to throw the ICU on top of that, that is a hard year. Emotionally, physically, it's just challenging. It's just something to think about. I went the path of going to med-surg before I came to the ICU, and I really think it fared better for me. And it just skills that I learned in the med-surg unit was just so valuable. I'll let Heidi speak to
about all those skills that you'll learn. So I think that Todd is correct in what he says. We are very used to having new grads on a med-surg unit. We have a system, I think across the board, especially in oncology, we do have a really great support system for all of our nurses, not just our new grad nurses. But I think one of the great things about acute care, especially at Nebraska Medicine, is you do see a lot of complex patients even in acute care. So the patients that we care for on our unit in a smaller hospital might be in a progressive care or an ICU. We still are able to do drips. We're still able to do different things like that. So you really get to learn that why patients need to move up to the ICU or to a higher level of care. So you still get that. So for our new grads, though, I think that we are a very supportive unit. We have a lot of things that you can learn, and we have systems in place to kind of support you and bring you through that first year of nursing, so that you are learning those technical skills that you need to care for all of our patients and providing that really good baseline foundation of clinical skills. But you're also learning how to ask questions, how to notice those subtle changes in patients. What happens when they get out of the ICU? Like, what does that look like before they go home? Because those are really great skills to take with you no matter where you end up. And I have a lot of nurses on my unit that really find that they just really enjoy that type of patient population. Being able to talk with your patients, is something that's really, really nice. Being able to kind of build those relationships in a lot of different ways where you can see them through the entirety of their care is really fun. And I think you get that on a med-surg unit. You also get to help people go home, which is what most people get really excited about. So being able to be a part of that, whether you're a new grad or not, is fun. I think Nebraska Medicine does a really good job of supporting their new grad nurses on whatever unit. Part of what Todd and I and the other managers feel, we feel very strongly about helping make our staff successful in whatever they do. So if it's to prepare you to go on to a higher level of care, I want you to be, like, what can we be doing to get you there? If it's, you love med-surg nursing, how can we continue to help you grow in that area? So I know Todd and I both have very similar philosophies on that growth and development piece. And yeah, I think that answered your question. Did I answer your question?
Yes, thank you.
Perfect.
And then similar to the last question I answered, what would make each of your units ideal for experienced nurses?
So there's just so many different varieties on our unit. We predominantly take oncology population. With that, though, the winter months are typically our highest acuity, and the summer months it drops a little bit just because of the nature of the population. We get a lot of people that come in with ARDS. We have to prone them, which requires a lot of intensive care and teamwork to get them turned over when they're on the ventilator. But it's a good unit to, even as an experienced nurse, to grow on and develop skills, as well as learning to work with the other units, because our tower works so close together and team-based that like nurses in the ICU are often helping out and helping the other staff they may be called to check on somebody to get their opinion or whatnot. And it's a great experience for networking when you're in the ICU at Buffett.
And I think I would add to that too. We talked about this a little bit in the last session too. I think we're very fortunate at Nebraska Medicine to have a really strong oncology program. So it's not only just a program that's known regionally, we are a nationally recognized cancer program and cancer system. So we really do provide a lot of complex care to our patients. Our staff get to be involved in research. We get to, do some cutting edge therapies for our patients. We get to kind of see patients from all over the country and all over the world, which is really fun. I think that because oncology continues to evolve and we're at an academic facility, you constantly are getting to learn. And I know that I've been in oncology for 14 years. Patients that we weren't able to treat when I first started out my nursing career, we now have better therapies to help them treat. So you get to see across the continuum of care just like how patients and how treatments are moving forward. I think oncology is a really great area to do that in. And so whether you're a new grad or an experienced person, you get to be involved in some of those things. And I think that keeps you learning and growing in your nursing career, which is always beneficial. I think Todd and I would both agree that our units are units that every day is different depending on that patient population that you kind of have there, depending on their acuity. So it means that every day that you're growing, every day that you're learning something new. I learn something new every single day that I'm at work about our patients and how we can better care for our patients, which is really nice and fulfilling as a nurse.
Great. Thanks again for both of your answers. Any questions from anyone so far?
Yeah, I got a quick question. It's kind of UNMC specific. I'm a semester 3 student, so we're preparing to kind of fill out that preceptorship questionnaire. Are there certain floors in Werner or Buffett that, take preceptorships or preceptors more so than others, or certain floors to look for when we're filling out that survey?
I think we all take preceptors on our units, so it's a great way to get a feel of not only what the unit is like, but if you've been in the cancer center, the units all work really close together, and so all the units take preceptorships. And to answer the chat question, yes, we do actually participate in research and evidence-based practice. Actually, the ICUs specifically, and I think they're talking about rolling something similar out on the floor on like Heidi's unit, is we have a nurse educator that works with the College of Nursing that's research-based, and she helps our staff in the ICUs kind of come up with research projects. She helps them, write their articles, build the research, kind of come up with different ideas. She helps them get, we've had one nurse that got published in Critical Care magazine when we first opened, and we do a lot of cool projects, different things. So there's a lot that goes on with research at Nebraska Medicine.
I think from just like an oncology standpoint, our hospital, like the cancer hospital, is actually made up of 2 different parts. We have our hospital side, which provides all the clinical care, but we also have our research side. So Todd's in my unit are really right across the hall from 98 research labs. They're doing anything from finding new diagnostics to new treatments to learning more about specific cancers. So we're very fortunate to be in very close proximity to our research. What that also means is that we do get to participate in research, oncology research. I know my unit has been involved in a radiation clinical trial for a new radiation therapy for AML, which is traditionally a challenging disease to kind of get under control. And so we are able to take care of that. We work very closely with our research nurses and our radiation safety team to care for those types of patients. So being able to also take care of your patients, just your general patients, but then you have the opportunity to participate in some of those clinical trials that might be the new thing that we can use to effectively treat our patients. That's not specific to just oncology. I know when I was on the COVID unit, we were part of the remdesivir trial. There's new trials all the time about new treatments and therapies for COVID that they participate in. And so being able to be a part of that is also something that's very interesting as a healthcare provider for that. So it's not every day that you get to do research, but when you do get to do it, it's fun. And like Todd said, being able to have that clinical nurse specialist coming in and helping provide that, I was saying, hey, like you could actually make a research project out of this, is really fun. I know Todd and I have both worked on several projects where we've been able to present some of the work that we've done at national conferences through poster presentations and things like that, which is really nice and something that you don't always hear about.
Thank you both for those great questions. Any other questions that you might have?
How long is the orientation period? Because I was in the pediatrics, they were saying it's like anywhere from 8 to 12 weeks. So how long does it take to get like oriented before you're able to kind of care for patients?
So I'll start this one. So probably, what was it, Todd? About a year ago, we in the cancer hospital changed how we did our orientation. So we do our orientation slightly different for our staff than the rest of the hospital does, but it's been proven to be successful for us. So I think it's going to be implemented everywhere else. For my unit for acute care, we take 6 weeks to orient our staff. And then as you go up in acuity, it's a little bit longer. I believe Todd's is 10 or 12 weeks.
It's 10 weeks.
Perfect. So what we have incorporated into that is doing, for my unit, at least your first 2 weeks that you're on the floor, you're working Monday through Friday. So you're working 5 8-hour days. That way you're really learning and being able to ingrain some of those beginning of your shift skills. Very easy when you are working 12-hour shifts to work on Monday and then come back on a Saturday. And everything that when you're new, that you learned on Monday, you have to relearn on Saturday. So we've been able to set up this system where you come more consistently those first couple of weeks and really hardwire in some of those skills. I think both Todd and I would say that we are really successful with this model of orientation. And it really helps support our staff, not only from a clinical standpoint, but you also learn the layout of the unit a little bit, or you get to socialize with and interact with more people. You're seeing your physicians more. You're getting a little bit more familiarity with just the team in general. I mean, some of those things that you just like don't think about when you start a new job of like, where's the break room? If I need to go to the bathroom, like where are those things? How do I find where the blanket warmer is? Now my patient, they want that. So being able to be there a little bit more frequently helps ingrain some of those things. Plus you get to see Todd and myself and our clinical educators a little bit more, so we can help with some of those things, make sure you're getting the experiences that you need, and finding those opportunities as well.
Yeah, so in the ICU, we do for a new grad, we do a 10-week orientation. The first 3 weeks are the 5 days a week. We used to do 12, so we dropped it 2 weeks. For experienced nurses, it's 6 weeks. And it depending on how they already are in terms of if they've been down to our unit and floated to our unit and been on that, we've got someone who we actually are going to trial doing 4 weeks. And they were all on board with doing that. A lot of times, you guys, orientation is really to just set you up with the tools to do your job and where to get answers when things come up that you haven't seen. You will not see everything in orientation. What orientation really does is kind of show you, okay, I've got this patient. I've never had this type of thing before. Where do I get the information to care for them? Because just by nature of the hospital, there are certain procedures we do more during the winter than we do during the summer, or vice versa. And so that's kind of how we modify orientation.
Great. Thank you both for your answers. And I saw your other question, Jeff. After this nursing open house, we'll be sending follow-up emails. And then if you have any further questions down the line for Heidi or Todd, I can make sure to pass those along to either of them. And I think we might only have 1 or 2 minutes left. If anyone had any other questions, or if Heidi or Todd had any closing remarks, either on what makes their unit unique or just on the culture in general.
So I've worked at multiple other hospitals. I started at Nebraska Medicine when I finished my schooling. And then after that, I went traveling for a while across the country. And I've worked at other hospitals in the region. Having done that, I started out as a med surg nurse. When I decided to take that next step to the ICU, I knew there was only one place I wanted to work, and it was Nebraska Medicine. I just felt like when I worked there, it just put me above and beyond other places in terms of experience for the nurses. The way they develop their relationship with providers and teams is huge. And while Nebraska medicine seems really big, it's really not. I've been there now 16 years since I've come back. And in that time, I mean, I feel like I can walk around the halls and know almost the majority of the people that work there. And that is what's really cool about it, because everyone really helps each other out in terms of, you know, reaching for success. And it just creates a great environment.
I would just add one thing. I agree with Todd on that. I think from an oncology standpoint, I've been doing it for 14 years, and I can honestly say, with a little bit of bias, but I can honestly say that oncology patients are some of the best patients you'll ever take care of. They're complex from like a medical standpoint. They're interesting and they're complex. Even in their most acute, or even at their lowest level, they're really interesting from a medical standpoint. But from a personal standpoint, they are patients that, 15 seconds, that will want to get to know you, that are very grateful for the care that you provide them. You will have wonderful relationships with your patients when you work in oncology. So hopefully you all